Hi, this is Sakib Rahman from the Orthoclips podcast series. And today I am with Surena Namdari MD. He's shoulder and elbow surgeon and associate professor of orthopedic surgery and director of shoulder and elbow research at the Rothman Institute and Thomas Jefferson University Hospitals here in Philadelphia. And we're going to be talking about C. acnes and shoulder surgery, diagnostic challenges. Thanks for coming on the show, Surena.
Thanks so much for having me. It's an honor to be here, and I'm really looking forward to it.
Great. Yeah, I know we've kind of worked together on a lot of educational live programs, but with this COVID-19 going on, I wonder when the next one of those is going to be. But glad to have you online here. And I'll first ask, how did you get interested in investigating this issue? Was it a particular patient or a case, or just by chance? How'd you get interested?
I think it's one of the black boxes in orthopedics, particularly in shoulder surgery. It's an area where we have some data, some research, but not a lot of answers. We've for years had cases of shoulder arthroplasty that didn't do well, and we thought that they were cases of what we would call aseptic loosening, which were not infected. And then this bacterium popped up on the scene, and it's a bacteria that was called Propionibacterium acnes, or P. acnes, and has been recently relabeled by epidemiologists to C. acnes to encompass a wider spectrum. But it's a bacteria that predominates in the shoulder region as opposed to other areas of the body. And as cultures were held longer, and as cultures were taken on medium using both aerobic and anaerobic means, we saw more and more samples positive for C. acnes after failed shoulder arthroplasty. And so because of this, it was hypothesized that perhaps many of these cases that we thought were aseptic were actually septic, and that C. acnes was the impetus or the cause for the loosening or the poor result, whether it was pain or stiffness. I think that one of the major challenges of C. acnes is that it doesn't present like a typical infection. And so, when we think about infections in orthopedics and we think about septic joints, we're thinking about the red, angry joint with purulence, maybe even fever, gross signs of implant loosening or failure. But you don't see that routinely with C. acnes. You don't see sinus tracts very commonly, and mainly patients have pain and stiffness. And so we don't have great way to clinically diagnose it. And then perhaps even more difficult is that our usual means of diagnosing an infection, either using serum markers like ESR, CRP, and white count, or aspiration of a joint, is not reliable. Those tests are almost always negative when it comes to C. acnes. But in studies that have looked at revision cases that they thought were aseptic, there's a high rate of positive cultures. And so about anywhere from 20 to 50%, depending on the study that you read, of our cases that are revision surgery without any overt signs of infection are positive for C. acnes.
So I think you're getting at my second question, and I think it's worth reiterating again. When we asked to talk about the topic with you, I kind of said P. acnes or Propionibacterium. So I would imagine a lot of our listeners didn't really know that it's now C. acnes. So I'll kind of reiterate that. But getting at my second question, which was, why is this such a problem? I think you outlined a couple of things. It doesn't seem like your obvious hot infection. You're picking it up in cases that didn't seem that they were obviously infected, kind of like that unexpected positive culture that you guys get when you do a revision and you just kind of check your culture, or like I get when I do a non-union repair and you realize that a culture came back, but it didn't look infected. So I guess I would imagine that's one of the problems. Any other reasons why this is such a particular issue that is, worth taking a close look at and focusing on? What other problems does it pose?
Yeah, I think this is a problem that we've investigated a lot in the shoulder, but I don't think it's necessarily going to be unique to the shoulder. You will, if you scour the literature, you'll see reports of C. acnes infection in other disciplines. In trauma surgery, as you know, some non-unions around the shoulder, clavicle, have been linked with C. acnes. In the spine, they're seeing it in some of their revision surgeries, and then hip and knee arthroplasty, they're also seeing it. And so, the major difficulty with this organism is that we're seeing it in our cases of revision surgery that don't show clinical signs. And so, on its face, that seems like a huge problem, because you would think that 50% of our revisions are infected. And so, to put it into context, if you take a group of patients who are having primary shoulder replacement, they've never had an operation before, and you sample their deep joint during the course of their surgery, at least 20 to 30% of those cases are going to be positive for C. acnes. So it's a bacteria that is in our surgical wounds. We realize that our surgeries are not completely sterile, and every time we make an incision in the shoulder, we're releasing C. acnes from the hair follicles that live in the dermal layer below the skin surface. And so we don't necessarily know what it means to have a positive culture in the setting of revision when we don't understand what a positive culture in the setting of a primary arthroplasty really means. And so it really adds another layer to the complexity. And so currently, because we don't have great diagnostic tests to use preoperatively, we rely really heavily on our culture results. And our culture results have problems. They can be contaminants. There can be deep inoculation from the skin level that wasn't really the organism was never really deep inside the wound, but you sampled it because some of it got deep when you made your incision or your approach. Or it can be a contaminant later on in the lab, or from even the air. We swabbed the air in our operating rooms for 5 seconds sterilely, and sent those samples to the lab, and 15% of them were positive. So this presents a huge challenge, because we use that information to make clinical decisions and decide who to treat. And if you look at complication rates that happen from using aggressive IV antibiotic treatment, they're not insignificant. Anywhere from 20 to 50% of patients who have IV antibiotics via a PICC line will have some kind of a minor or a major complication. And so it's not a small thing to diagnose somebody with an infection after any kind of surgery and then move on to fairly aggressive treatment when we're not really sure that they have that kind of a problem.
So what you mean is that finding the bacteria doesn't necessarily mean clinical infection. Is that what you're getting at?
Yeah, I think that's right, because we assume that the cases that we're doing primarily that do not get routinely infected are not infected at the time of surgery. Even though we're seeing bacteria sampled in let's say 30% of our primary shoulder arthroplasties, we don't consider those to be infected cases. And so because of that, if we see 30 or 50% positive in revision cases, we don't know which ones of those are true infections and which ones are not true infections. That's the biggest challenge right now in terms of the diagnosis. We don't have a perfect way to determine which P. acnes are simply deep inoculants coming from the skin and sampling errors during surgery and don't matter and don't need to be treated, versus which C. acnes or P. acnes are deep sources of implant loosening and pain and should be aggressively treated.
Yeah, this is an interesting concept, because there really isn't a whole lot of analogs that I can think of that we have, or we have other bacteria that we think about the same way. I mean, if I have a problem and I'm finding staph, that's getting treated. But something like this, it's almost like, you just because you find it doesn't mean you have to treat it. I mean, I think it's a biofilm forming organism as well. And I think you find it on, like you said, in the clavicle plates. I think it's been found in the absence of clinical infection. So what else does the literature tell us, either, literature you've been involved in, your investigations, or others, about the challenges in treating these? Maybe we'll just focus a little more on treatment.
Yeah, I mean, I think the treatment part of it is actually a little bit more encouraging. If you look at the results of single stage revision, where you go in, you clean out the joint, you remove the implant, and you put in a new implant at that same setting, and then you treat the bacteria postoperatively in one surgery, one sitting, the results are actually very good when it comes to indolent or low virulent organisms like C. acnes. So over 90% of patients will have eradication of the organism and no recurrence. And so that's at least reassurance that even though we can't necessarily make the diagnosis, single stage revision can be effective. And it's not to say that every one of our joint revisions needs to be a two-stage procedure, which can lead to more morbidity. I think that the other important factor in terms of how we treat our patients is that because this organism is so difficult to diagnose and even harder to really understand, at this point, you really have to treat all of your surgeries as though they're contaminated, whether it's a primary or a revision. So, when I do my primary arthroplasties, I will pretend like it's an infected case. I'll irrigate with 3 to 6 liters of saline at the end of the case, and just assume that there's deep inoculation of the tissues with C. acnes. There isn't great data yet on dilute betadine or vancomycin powder in these settings, but if there are higher risk patients, then I will use those adjuncts.
That's interesting. Getting on my next question, and maybe just give me a clinical scenario, and how you approach in your practice a shoulder surgery patient, specifically in mind to stay out of trouble with P. acnes. What are your steps in your practice that you take? You just kind of named a couple: treat them like they're infected. Anything else? Any tips, kind of practical tips for other surgeons to stay out of trouble? I mean, you can think of me as well doing, I just fixed a proximal humerus 2 days ago. Was there something maybe I should have done that I didn't think about? Thinking about prep. I know you've written about pre-op antibiotics, all the things we do to prevent infection. What do you do differently for, I should say, C. acnes? Sorry.
Yeah, I think there are a few things that you can do. So in terms of preoperatively, the one thing that has been shown to be effective in reducing the P. acnes culture rate or C. acnes culture rate is benzoyl peroxide. Now, I do not routinely use that. The reason is because you have to use it for at least 3 days, and it's a patient compliance issue. So I don't routinely use that, but it is an option. The other is being able to identify the patient who's at risk, and typically the patient who's at risk is the younger male patient. Those are the patients with the higher concentrations of C. acnes. And so for those people, we do consider the things like dilute betadine or vancomycin powder, and I'll use both in that patient population. Routinely in every patient, we've changed our prep. And so instead of just a betadine type scrub followed by a chloroprep, we have added a layer to that, and it goes in the middle, and that's a hydrogen peroxide wash. And so we've shown in one of our studies that it reduced the P. acnes or C. acnes load in the skin with dermal biopsies by 50%. And so I think that's a very simple adjunct that any institution can add. Hydrogen peroxide is cheap. It doesn't rely on patient compliance, and you can simply add it to your prep. And so we do that routinely. After I make skin incision, I get rid of that knife. That knife goes away, and it is not used for the rest of the case. It's off the field. I think that's something that anybody can do as well. Postoperatively, I do not routinely put patients on antibiotics long term. I do worry about the potential impact of antimicrobial resistance. So I don't use a lot of that. You know, the one thing that we really don't know the answer to, we're trying to use all these techniques to decolonize the skin of C. acnes. We don't know what that does to the microbiome. There is likely an influence, and the concern is that if we get too aggressive in terms of eradicating an organism that we don't completely understand, then we could encourage the overgrowth of pathogens that we really may cause more clinical problems.
Excellent. So to wrap up, I guess I'll just ask a question about the future. What do you see coming down the road in terms of diagnostic methods? Alpha defensin, immunofluorescence, next-gen sequencing. And, you know, I talked to one of your colleagues, Dr. Parvizi, on a recent podcast, and interestingly shared a lot of similar sentiments you did about, you know, the fact that a lot of our so-called aseptic revision cases may in fact be infected until proven otherwise. And also, one other thing he said is that he really thinks the future in total joint infection diagnosis is not going to be cultures, but it's going to be, you know, sequencing and other more accurate methods of diagnosis. What do you see happening? What's happening in the research world to try and improve upon our current, you know, problems with diagnosis?
Yeah, I think Dr. Parvizi's points are right on. I mean, the problem with cultures is that they're so reliant on so many things going right in order to be accurate. And we already know that we have a test when it comes to C. acnes that in 30% of primary cases is positive. And so makes it almost impossible to interpret it in the setting of revision to diagnose infection. And so in order for us to determine which bacteria matter and which ones don't matter, we're going to have a better tool. And so some people are looking at possible different strains of C. acnes, possibly looking at whether hemolytic versions versus non-hemolytic versions are more likely to be pathogenic. We have looked at next generation sequencing. There are different levels of next generation sequencing, and the technique that we've looked at, interestingly, the cases that you would consider to be infected with C. acnes based on culture were not the same cases that you would consider to be infected by next generation sequencing. So we're left with even a more complex problem, which is are the cultures right? Is the next generation sequencing right? Are they both wrong? Or are they both right? And they both have a role. So I think the further research that's going to come is going to be directed towards a better molecular test that can help us determine which bacteria are really causing problems within the joint versus those that are just simply part of the microbiome and maybe travel down deep into the joint. And there's probably a patient-related factor that we don't completely understand. Some patients can likely be inoculated with bacteria that are indolent and they cause no functional problem, and their immune system is such that they can, that bacteria becomes part of their normal flora, versus other patients that maybe are more immunosuppressed or have a different immune response to even an indolent organism. So I think that those are the things that are going to become more elucidated in the future as we continue to look at this.
Yeah, really fascinating stuff. So yeah, a lot of stuff. I think that it's a topic of interest to a lot of people, not just people who do shoulder arthroplasty, but those of us who have to deal with any type of implants. And I think even to some extent, shoulder arthroscopy is not immune to this. So I want to thank you again, Surena. Again, I've been with Surena Namdari, who is at the Rothman Institute. Thank you again. We've been talking about C. acnes and shoulder surgery diagnostic challenges. Appreciate you coming on the show.
Thanks so much for having me. This was a lot of fun. And I think Yeah, I've seen your podcast. I think this is a great resource for residents, medical students, and really anybody who has an interest in orthopedic problems.
Thanks. Appreciate the love.